Yo, yo, yo. Hey guys, welcome back to another amazing edition of the Best Practices Show. Today I bring back a great friend of mine, Dr. Jim McKee, and he presents a question. Here it is. Who am I the answer for as a dentist? It's a very important question that will change your practice forever. So please listen to this. I hope you guys enjoy it, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. Have you ever thought to yourself, I'm building this practice, but who am I building it for? I mean, I'm solving problems for patients, but who am I really the answer for? And there's no one better to ask good questions to help us answer the question, who am I the answer for, than Dr. Jim McKee. Jim, thank you, brother, as always, for coming back again and again and again.
Great to be with you, Kirk. Thanks for the opportunity. I always enjoy these, so it's just a blast. Thank you.
Pleasure's all mine. I say this every time you're on. The value of having great mentors is priceless. And so you guys are in for a treat today if you haven't heard Jim before. You're going to see why he's one of my favorite mentors, and I get the privilege of speaking with him this Friday, which we'll talk a little bit about here in a second. But Jim, let's start here. I want to unpackage this question. Like, what is this question all about?
You know, let me tell you the history of this, Kirk. I heard this question from a lecturer at a Seattle Study Club symposium probably 5, 6, 7 years ago. And I wish I could remember who it is because it was a really great lecture. It was a non-dentist who actually asked the question. And the question just stuck with me. Question is, who are you the answer for? And, you know, I see dentists now taking a shotgun approach of trying to market their practice in all different ways. Ultimately, I think if we take a step back and say, who are we the answer for? What it does, it allows us a lot of clarity in terms of trying to create a vision for our practice, trying to help our team members understand why they come to work every day, trying to be able to communicate effectively with patients. So the real question is, everyone on this podcast, who are you the answer for? When we're in dental school, I was taught you're the answer for everyone from a clinical perspective. And I think it's still the case today. When you see dentists graduate from dental school, most of the time they'll do crowns, they'll do composites, they'll take out wisdom teeth, they'll do root canals, they'll work on kids, they'll try and do perio, they'll try and do airway. But here's the problem. Most of our training in those procedures are enough at the dental school levels to get us a degree. But once you get out into clinical practice, all of a sudden now, if you have a root canal that comes in, that's already been treated once before, the root canal is failing again, there's a large curved root on the upper first molar that's calcified. What are you going to do with that tooth? You're probably going to start to send it to the endodontist. In my experience, when I didn't have as much, when I was a younger dentist, quite frankly, I would take on everything. And as I matured as a practitioner, what I started to notice was I was referring more things out. I think in dental school, we kind of have a scarcity mentality. And a lot of times that doesn't go away from dentists in their entire career. We're always worried that the book isn't going to get filled.
Right.
There's more than filling the book. I look at a lot of practices that have patients who are stacked one on top of each other, and the dentist is booked out 8, 10 weeks in advance. And yet they tell me I'm working harder than I ever have, Jim, and I'm not doing very well financially. There's a difference between being busy and being productive.
Right.
And I think when we talk about who are we the answer for, We need to be the answer for our patient, but we also need to be the answer for our practice. We need to be the answer for our staff. We need to be the answers for ourselves because most of us are single practitioner dentists. That means we're the whole shooting match. We have to pay all the overhead. We have to put money away for retirement. We have to put money away to update our equipment. And all of a sudden, that has to come somewhere. So the question is again, who are we the answer for? And I would start to say what we start to see as dentists start to mature, they start to focus in doing more crown and bridge, more restorative dentistry, composites, maybe some implant placements, all great ways to generate revenue, but we tend to farm out the things maybe that we don't want to do as much. Is that what you're seeing, Kirk?
Yeah, totally. And I want you to go there. This question is a big one, and I think as you learn more about yourself, trying to figure it out by yourself is a hard one. That's why a lot of people, as they're doing all of this, they search out going to Dawson, going to Pankey, going to Coyce, hoping to find an answer for who am I the answer for? And it's a lifelong journey. So can you talk about that?
Well, yeah, I guess here's the other issue. Let's say you're a relatively new dentist and you talk to a dentist who's been out for a while and has some experience. Well, that was a great practice model 40 years ago, because 40 years ago when a dentist came out of dental school and they walked into their practice, and let's say they were a 28-year-old new dentist who had been out for a couple of years, if they had a 28-year-old new patient who came into their practice, the odds were pretty high that that patient had several MOD amalgams that were going to break down over the course of the practice career. And there was going to be a lot of restorative dentistry to do in that patient base over time. That was certainly my experience. However, when I look at younger dentists today, the dental demographics have changed. We have done a really good job almost putting ourselves out of business from a caries perspective. Now, I know there's still areas where you have lots of high caries, but in general, when you talk to most dentists, what they're going to tell you is they see the rate of caries decreasing. So all of a sudden now that 28-year-old new patient who comes in for the 28-year-old dentist who graduated in 2021, all of a sudden there's not going to be all that restorative dentistry that needs to be done over the years. And as a result, now there's a void in the revenue stream.
Right.
And now dentists start to get nervous because, again, it goes back to the dynamics of having your appointment book filled. Appointment book is kind of the archaic term that was in the paper days. But when you look at your computer and your schedule has open slots in it, there's nothing worse for a dentist to look at the schedule and see open spots. Creates a pit in your stomach. You kind of get depressed. You kind of start doubting your practice. And that's what leads to some of the frustration in dentistry. You start to see yourself stretching, talking to patients about things that, yeah, maybe they could use but aren't really critical because ultimately you're trying to fill the book. So that's why I'm saying when we talk about who are we the answer for, there's a lot of patients out there who need our help, but it may not be in the crown and bridge realm.
Yeah.
Kirk, any thoughts on that?
Totally. So every business in the United States that ever existed solved a problem. And the better you can get clear about the problems that you solve, you can ultimately start to say, who am I the answer for? Yeah. And that's when we get into differentiation. We go down this path. Now, there's things that make this complex, like third-party reimbursements along the way. Can you talk about that?
Yeah, I mean, here's the problem. It kind of goes back to the same question, who are we the answer for? Before third-party reimbursement, it's as much an in of out-of-network discussion as there was. We could be the answer for pretty much anyone.
Right.
Because pretty much anyone could come into our practice. They had decent insurance coverage. Back in the day, If a dentist graduated 40 years ago and the annual maximum benefit was $1,500 and the average crown was $300, you could do 5 crowns in a year and have that covered by insurance. Today, the average annual maximum benefit is still $1,500, but that may not even cover 1 crown in some practices. So all of a sudden now, the amount of insurance reimbursement that we can depend upon from a cash flow perspective in our practice has markedly decreased. So there has to be a way that we understand that, and we can rationalize from a practice management perspective, how do I think about generating revenue in a different way? Because I don't have 5 crowns I can do on a patient and say, oh, don't worry about your insurance will cover it. That's not the case today. So we have to be able to talk to patients about the different services that they need without as much help from insurance reimbursement as we used to be able to have.
Yeah. And now you're going to also point us in the right direction. As you start to look at this, there's 2 buckets. You're going to be looking at the treatment bucket, but you're also going to be looking at the managerial bucket as an entrepreneur. And they're not always the same. Can you clarify those 2 buckets?
Absolutely. Again, when we say who are we the answer for, there's a technical answer that you just mentioned, and there's a non-technical or a managerial question. Again, as a younger, inexperienced dentist, I took everyone. Didn't matter. Some patients were really great to work with. Other patients would miss every other appointment, or they'd pay late, or they'd arrive 30 minutes into the appointment and then want you to see them, or they were rude to your staff. All those things, the patients that when you looked on your schedule, you're like, ew, I hope they cancel. I never put 2 and 2 together. The first place I heard this was down at the Pankey Institute. It was a classification system that Dr. Pankey used for his patients. Really easy. And I'll tell you, who's ever listening to this podcast, the next couple of minutes, I think, are going to change your professional career. What I'm going to share is what I heard that day at Pankey, and I have used it every day in practice since. 2 criteria to evaluate patients coming into your practice. The first one is their appreciation for quality or comprehensive dentistry. Are they more of an insurance-only patient? Are they more of an emergency-only patient? Or do they want to find a dentist that they can work with and maintain their teeth basically for the rest of their life? We used to see a lot of people losing their teeth. We don't see that as much anymore. So now the question becomes, not only do you want to keep your teeth for the rest of your life, but how easily do you want to keep your teeth for the rest of your life? Because if we can start to recognize that, hey, people are going to hang on to these their entire lifetime, kind of changes the way people think about the process when you talk about different things to patients. Today, I talk about tissue grafting to patients in their 50s and 60s way more than I used to. Because as patients get older, we know that one of the biggest things that causes patients to lose teeth or have problems is decay along the root surface. I've had a lot of patients who live into their 80s and their 90s who are fine until they come in one day when they're 81 years old, and all of a sudden they say, I've got a little pain on the lower left molar. And you put the Explorer underneath there, and the Explorer buries into this huge area of decay, not coming from an open margin on the crown, but coming from caries on the root surface that have now infiltrated up underneath the crown. It's not that the restorative dentistry gives out, it's the root surface that gives out. The best way to protect the root surface is to cover it with gum tissue. So that's what I mean in terms of talking to patients differently. I do a lot more referrals to the periodontist now for doing tissue grafting to try and maintain that root surface to avoid those problems as things go on. So basically, a patient that has a high appreciation for dentistry normally will do what you ask them to. They'll go to the referrals that you ask them to. They'll show up on time. They'll do the treatment that you outline. But then you have to get the real world discussion as well, because there has to be, the one criteria is how much we value dentistry. The second is what's our ability to pay for it. I mean, that's the reality is we all have to pay our rent. We have to pay our staff. We have to pay our supplies. We have to pay our utilities. Hopefully we can put a little bit enough so we could retire one day. We have to save so we can take continuing education to improve our skills. All that has to happen from revenues that are generated in the practice. So it's great if you can have a practice where everyone loves you and everyone says yes to everything that you recommend. But then when they go up to the front desk, they say, do you have a payment plan? I'd like to pay that over 20 years. There's no way you can do a cash flow to be able to get your money out of the practice and the resources be out of the practice to be able to support yourself. So that's why I think we have to be able to look at the patient's ability to pay a fair fee. Great line by Dr. Pankey: a fair fee is defined as a fee that the patient pays with gratitude and the dentist accepts with gratitude. Part of the problem is today for young dentists, they have a hard time accepting with gratitude because most of the time I just talked to a younger dentist the other day. He is in a large insurance-based practice. He's got 3 opportunities every minute, actually, because they work in a 45-minute schedule. The dentist was saying I'm run ragged. They don't feel like I'm helping the patients. I feel like I'm doing triage, like a MASH unit in a war zone, which I understand. And honestly, that's some of the situation. Answers. So if that's all the patient is used to getting, that may be what they think dentistry is about. So I think today dentistry can be about more than that. Now, again, every patient has to be looked at. What's their appreciation for quality dentistry or comprehensive dentistry, and what's their ability to pay a fair fee? If you don't look at those questions, here's what happens. You assume that everyone thinks the same way as you do, that dentistry is the most important thing in the world. Well, obviously, other people have other things going on in their life. Cars, kids, in-laws, parents, all that stuff. Sometimes they just need a triage or a fix. But ultimately, if we're trying to figure out which of the patients that we're going to try and build our practice around, we need to take a big picture of which of the patients will be ready to value comprehensive dentistry. Either way, or that may take a process over 2, 3, 4 hygiene appointments to start and create that value. The other thing I want you to hear is that sometimes it doesn't happen at all. There are some patients, no matter how effective you are a communicator, that they don't value their teeth. And therefore, those are the patients you have to think about how you want to allocate your appointment time to them. I'm not saying don't see those patients that are below the line, the class 3 patients that have a low. So basically, the class 1 patient has a high appreciation for quality dentistry and a high ability to pay a fair fee. Those are the best patients in our practice. Those are the ones that get the best appointment times. Those are the ones, if they have a problem, they're told to come in immediately. They're the frequent flyer patients who have been to your practice for years and have supported it. So whatever they need, they get. Class 2 has a high appreciation and a moderate ability to pay a fair fee. Lots of patients like this over the years, probably the majority of patients that we see and do restorative dentistry on. Many times we have to phase a case. That's okay. You know, I've done a lot of full mouth rehabilitations over 4 or 5 years, doing a segment at a time, because that's the way people had to do it from a financial perspective, and there's nothing the matter with that. The next patient is a 2-. That's someone that has a high appreciation, but it has a low ability to pay a fair fee. Might be a retired couple on a fixed income. It might be parents supporting their parents in a nursing home, recent college graduates, single parents. There's a number of different people out there who need our help. And honestly, I think this is one of the nicest ways to give back in our community. So for these patients, we'll make a fee allowance for them. Many times we won't even tell them because it's something we want to do for the patient to give back to our community. But those are the patients I'd rather help financially instead of the class threes, which are usually the ones that we do. The class three patient has a low ability, means they don't keep regular appointments, like I talked about before, the ones that don't show up, the ones that are late, the ones that are rude to your staff, the ones that don't pay. But here's the interesting thing. They have any ability to pay a fair fee. They have a high ability, a moderate ability, and a low ability. It's really the value that is the bedrock of this classification system. It's not the finances. Anyone who hears this classification system says, oh, that's a lot about money. No, it's not. It's
Yeah.
about the value. And basically, my role in the practice today is to create an above the line patient base.
Yeah.
Doesn't matter what they can afford. My goal is to create an above the line patient base because like refers like.
Yeah.
Likely to have an above the line referral from an above the line patient than you are to have an above the line referral from a below the line patient.
Yeah.
So that's really the thought process.
Yeah, I want you to go back to that, the value versus the finance piece, because I think that's the part most get confused. And another thing I heard Dr. Pankey, I didn't have the fortune of meeting him, but plenty of education, was the prejudging thing. So I love what you're saying as you go through this classification process, which is basically above the line and below the line.
Right.
You got the second piece that's playing this little song in your head. You're like, there's no way they can afford this. And there's so many patients. If you do a good enough job of seeing if they're on the value plane, they will find the resources for this. Because if you're looking out in the parking lot to see what kind of car they're driving or all that kind of stuff, that can get in the way. So don't prejudge whether or not. We used to joke, and I don't know who started this one, but I love the idea of not doing wallet biopsies first. So can you speak to that?
I think every dentist makes that mistake. Every dentist thinks that they can get an idea of how much disposable income someone has for dentistry. Part of the problem is we think of dentistry as a disposable income. We may think about that if we've got all our teeth and we can function. If you're missing teeth and you can't function well, maybe that's not disposable income. Maybe that's necessary expenditures. So we have no way to know that. It comes from our own insecurities, though, Kirk. I mean, dentists are no different than anyone else. They don't like being told no. We don't like rejection. And that's most of the time what we're afraid of when we present a treatment plan is the patient's going to say no. You know what I found out? Most of the time when patients say no, it's not about the money. They may say it's about the money, but it's typically not about the money. Either they don't understand the problem, they don't understand your solution, or it's not the time in their life to do this. They may understand the problem, they may understand the solution, they may have the finances to do it, but it just may not be the time for them to do it for whatever personal reasons they may have. I used to be more judgmental about that when I was younger. And what I started to learn is that's not a real nice way to treat people.
Right.
Everyone's doing the best they can. So what I tell patients is I will try and give them some framework on when they should think about doing the work. Short term, intermediate term, long term. And I'll kind of lay it out for them. I said, really, this is a short-term concern. We should get to this as soon as you can do it. Intermediate, we want to look at this. We probably should think more about this over the next 6 to 12 months. And then we can move forward with doing something. We don't have to do it tomorrow. But the problem is the longer it goes, the more difficult it's going to be to treat. And generally, the more expensive it's going to be for you to have the problem resolved. Last thing is, this is a long-term situation. We're probably thinking 1 to 3 years in this situation. We may think about wanting to replace some of those fillings. Maybe we want to do a couple a year to help work with your insurance, but nothing's imminent right now. Now, that could change in the future, and if it does, we'll just change that from an intermediate or a long-term treatment option, and we'll just move it up to a short-term treatment option. When I started to do that became an easier way for me to talk to patients. and my case acceptance went up. I wasn't painting patients into a corner where I didn't give them any way out. That just took time on my, part of the issue is, especially when you gain a lot of information about a topic, whether it's occlusion, whether it's TMD, whether it's restorative, whether it's composites, whether it's implants, you automatically start to talk to patients differently. And sometimes we assume that patients have the same background that we do, and they're going to accept everything the way we think about it. We have to understand that's not the case. So that's why I think that we have to make sure that we can start to read the patient and get an idea of where they are. There's a lot of patients who came in my practice as a class 3 patient that I just presented phase 1 therapy to. You've got some old fillings, let's clean those out. We'll put some newer fillings in. Some of those may have to need crowns, but let's get these taken care of for now. And then over the years, through education and through creating value, they eventually said, okay, I know you talked about doing some other work on those teeth. Which one should we think about? Really, I think it goes back to what Dr. Pankey said. If you can go into a consultation with a few dollars in your pocket, it's an easier consultation. So many times we go into consultations with the patient needing to say yes so we can pay our bills.
Right.
I'm gonna give you advice in terms of trying to maintain a very low cost practice overhead. More importantly, a low cost personal overhead as well. I see a lot of dentists who get out of school and become house rich, car rich, country club rich, and cash poor because they're living a lifestyle that doesn't really support their income, but they're dentists, so they feel they're entitled to that lifestyle. I'm not saying you're not entitled to lifestyle, but it's awfully nice to have some savings so now you can make choices on how you want to spend your time, how you want to spend your money, how you want to talk to your patients is really what it comes down to.
Yeah, you're presenting such a great framework for this. And if you're a dentist listening, figuring out who you are the answer for, again, it's a tough journey. And you have to take this to heart. Can you talk about this too, Jim? It's not just for you. Your team has to be able to answer this question. So ultimately, Jim, I would imagine a lot of times in your career, team members would come to you and help you understand where this patient is. I think they might be above the line or below the line. We all got to be on the same page in learning about these patients, right?
Absolutely. And the interesting thing about these patients, honestly, is that a lot of times once you start to understand the patient and you can understand what their problem is, what you realize is that sometimes it's going to take you longer to figure out that problem than we thought. Because our training in dental school is fast, 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 fast. Because think about it. When are most dentists being paid? When the burr spins.
Right.
If the burr's not spinning, we don't have anything we can submit to insurance for billing. So therefore, our emphasis becomes on having a patient in the chair where we're making widgets. We're widget makers. We really are. We can make one very expensive widget. We can make 100 very inexpensive widgets, but we're widget makers. So what it comes down to is how complicated is the widget? How complicated does each patient present with their problems? In my experience, as patients move above the line or are referred to you by other practitioners in your community, and therefore almost automatically come in above the line because they're looking for answers as opposed to just price shopping, what we find out is that it takes more time to work up those cases than we thought. That's where the practice management dilemma comes in for the dentist, because the patient needs work, they're probably willing to do it, but I have a lot of work I have to do to get this ready. When I was a younger dentist, I had a lot of diagnostic wax up sitting on my shelf that I paid for that never got done. Quite frankly, because the patient wasn't ready to do it. I didn't read the patient correctly. Today, I'm going to treat that patient differently. I'm going to have the patient have some skin in the game. I can do a full diagnostic wax up for the patient, but again, when you start to take a look at that, depending upon what lab you use, you could be into $1,000 to $2,000 wax up. And if they say no, that's not a success. That's not a good sustaining practice model. Really, what started me changing my thought process was wax ups. And I finally started to say to patients, we can do a blueprint or a prototype. And basically would be like if you're going to put a deck on your backyard, you'd hire an architect and they would do blueprints. The diagnostic wax up is basically the blueprints. The fee for the blueprints is.
Right.
That's how I changed from doing the wax up to, quote, sell the case, to doing the wax up to help the patient understand what needed to be done. So I wasn't looking to sell. This was an collaborative discussion between the patient and myself to see what's possible in their mouths. So that's really, you and I have talked before about the restorative diagnostic practice. That was basically the beginning of the thought process to create the restorative diagnostic practice, were diagnostic wax-ups that were done without the patient accepting the treatment. And then you got a big lab bill you got to pay.
Right. It was a great way just to see if you and the patient were both willing to take the first step,
Right.
so that we could take more
Right.
steps together.
That shouldn't be my responsibility to do the wax up so they can see what it's going to look like. Now,
Right.
Today, obviously, we have digital smile designs that are way less expensive and way easier to use. Totally get that. So in the aesthetic world, it's different. But, we talked a little bit before that there's not as much restorative dentistry out there as there used to be. We still see people doing aesthetic work, no doubt. We see direct resins done beautifully. We see porcelain veneers done beautifully. We see full coverage crowns done beautifully. But honestly, not as many as we used to, especially on the posterior tooth level. There's a lot of patients who have come in who are 35, 40, 50 years old now with no fillings. The benefits of fluoride and sealants have really taken hold in this generation. But you know what they have all had? Almost all of them, at least. They've had orthodontics. And now the discussion gets interesting. Because most of the time, I've never really said this statement out loud, but I guess I'm going to say it now. Most of the orthodontic cases that we see usually had a growth issue either at the maxilla or the mandible level, or both. Most orthodontic cases that we see have some type of growth issue, that something didn't develop completely. And if that's the case, the primary reason that we see for a failure to thrive or grow typically relates to the TM joint. Now, there's a lot of talk about the airway world today, and that plays a role in it as well. But from the temporomandibular joint world, that's really, I think, is going to replace what the restorative dentistry was the last 40 years in terms of creating a revenue stream in the practice. The number of patients that have structurally altered temporomandibular joints, we were taught was 5 to 10% in our practices. That number is way too low. It's at least 50% of our practice. I mean, if you think about it, ask the average orthodontist how many new patients, what percentage of the new patients are class 2? The average orthodontist is going to tell you between 50 and 75%. I'm going to tell you that the 12-year-old class 2 female has a very high likelihood of having the disc not in the right position. Someone needs to evaluate that case. Why can't that be us?
Right.
The restorative diagnostic practice model really, I think, fits better today than any other practice model out there. Because what it does, it gives you one column for the dentist to do restorative work, and it gives you a second column for the assistants to do diagnostic records. In the TM joint world or in the restorative world, those records usually consist of a CBCT, virtual articulation with scanned models today, digital photography, and usually some type of joint imaging, typically MRI and CBCT. There has to be a fee for that. If Those patients who are above the line and understand the problem and understand the need for additional information in order to make a good decision, those patients are going to say yes to a diagnostic records fee. And all of a sudden now in a practice, you don't have to be running multiple hygiene rooms. You don't have to be booked 3 rooms at one time. You can see one patient. You have your assistants doing diagnostic records. Now you'll slip in there. You're going to talk to the patient. You might take a bite record. You might do some diagnostic nerve blocks to figure out where the pain's coming from if they have pain. But it's a way more relaxing way to practice. And what it does, it allows you enough time to understand what the patient's problem is, to be able to understand the patient's personality so you know how to talk to that patient, and it gives you enough time to work up the case clinically. I would bet if you talk to most dentists, Kirk, what they're going to tell you is a lot of the times when they go into a consultation for a big treatment plan, they're flying by the seat of their pants.
Oh, 100%. And they use words like co-discovery, which is, I didn't look at it, so we're going to look at it together. And then I want to go back to this because, Jim, what you're presenting is brilliant. Now, if you're a dentist listening, he said this on a previous podcast. But, Jim, there were days where your assistants outproduced your hygienists. Can you just talk about that? And
that's routine. That is routine in our practice. You know, the restorative diagnostic practice is basically based on a low exam fee and a higher diagnostic records fee. Now, you're going to have 3 appointments. You're going to have the exam. At the end of the exam, you're going to have to make a decision. Am I going to present for diagnostic records or not? Now, not everyone's going to need diagnostic records, so not everyone gets the presentation. But if they do, then you present for diagnostic records. That means they're coming back to get the diagnostic records, whatever you think it is. I'm talking in the TMD world, MRI, CT, virtual scans of the teeth, and photographs. If you're in the airway world, you may do something else. If you're in the implant world, you may do something else. If you're in the holistic dentistry world, you may do something else. Ultimately, though, honestly, I think the TMD is the least populated world in the dental side, so that's where the opportunities are the greatest. I'm always surprised to hear dentists say, oh, I don't have enough patients in my practice. I just sign up for an insurance program, but then they're referring their TMD patients out of their practice. Those are the patients that are willing to work with you, usually outside an insurance system. So if we can start to put that practice together, exam, appointment number 1 is the exam, appointment number 2 is diagnostic records, whatever they are, appointment number 3 is a consultation. So when you add up the total time spent on those 3 appointments, I think in my practice it's 2.75 hours. I think we leave an hour and a half for our initial consult if it's a referred patient, 15 minutes for diagnostic records to do nerve blocks or take a bite record, and then an hour for a consult. That 2.75 hours has to be multiplied by what your hourly production rate is to be able to maintain your practice. And that's the fee for the combination of your exam and your diagnostic records. Ultimately, it has to get there, because if it's not there, you're not going to do it.
right.
You know that it's a noble intent, but when the rent is due, the rent is due, and you've got to be able to do that. So our job is to help patients want to get diagnostic records, which is really in their best interest, because that way they can make a good choice for treatment. I was talking to someone the other day, Kirk. I said, I have seen so many patients spend so much money on treatment options that had no chance of working simply because the case had never been properly worked up. No MRI, no CT, no models. And now the patient loses faith in dentistry. And all of a sudden now everything else becomes a little more difficult to put the case together for.
Right.
So I think it's really our obligation to the patients to make sure that we have enough time So we can work up the case. So now they have enough information to make a good treatment decision instead of wasting money and time, quite frankly, and emotional currency, thinking that, oh, this is going to get me better, this is going to get me better, and they get no better. We need to do better about that in dentistry. Now, everyone wants to do the implants, the restorative, the ortho, but here's the other reality. It's really difficult to do any of that with confidence unless you know what's happening at the joint level.
Right.
So all roads lead to Rome. Start with the joints and go from there.
Jim, it's brilliant. It's brilliant. So I know I can't keep you all day on this, but I think answering the question, who am I the answer for, sets you on a path. You'll be so happy that you did that, no matter where it ends up. But give us some final thoughts on this.
We're the answer for patients we're the answer for above the line patients. That's what our practice is. We're the answer for above the line patients. Now, again, knowing that they all won't come in above the line, you may have to do some work and create that. That's okay. But our goal is to build an above the line patient base. That's who we're the answer for, because those are the patients that are generally going to do the dentistry that you're going to talk to them about. So that's who we're the answer for, is we're the answer for above the line patients. That's really what it comes down to. I think that's the most succinct way to say it. And if we can have that as a practice goal, that we're the answer for patients who value comprehensive dentistry, your practice will have a sustaining practice no matter where you practice and no matter the economic times.
Yeah.
I really do believe that. I look back at the times in 2008 when the recession hit and when it went down with COVID. Our numbers stayed solid because, again, people are coming to you not for elective reasons. They're coming through you because they want answers for things.
Yeah.
So that would be my advice, is to become the answer for above the line patients.
Because when you build a practice, when you build a practice with people above the line, you know who they refer.
Above the line patients.
Right. You get more of them.
Yeah.
So, Jim, this is amazing. Now, I want you to talk about this. What are you doing on Friday? I also want you to talk about your study club. I also want to talk about what else you're up to. You've got your hands in a lot of different things education-wise. Can you just tell us, if you're listening to this podcast, you got to follow Jim in some form or fashion. So where do I go, Jim?
This is a super fun phase of the career, honestly. I transitioned, my wife and I had a practice for 35 years. I did the restorative TMD and Lisa did the ortho. It was awesome. I'm losing your volume, Kirk.
Can you hear me?
Now I can, yeah.
Yeah.
Yeah. Okay. So it was an awesome practice. We transitioned 3 years ago, and really I'm in the office 6 to 8 days a month now. So it's really given me more time to do more teaching, to do more online work. Friday, I am going to be fortunate enough to present with the man, the myth, the legend, Kirk Behrendt himself. We'll be in Milwaukee at the DOT Fest, the dental online training program that was started by Dennis Hartley. Dennis is an awesome dentist in the Chicago northern suburbs and has put together a fabulous training program for dentists. It's really kind of a unique concept where basically dentists will send you the materials, and it's really an awesome training program that you can be part of. Kirk and I will be part of the presentation. This is their first live get together. So I'm really looking forward to being with Kirk to present together. So that'll be a lot of fun.
Yeah, it'd be great. Talk about your study club too.
Chicago Study Club. For me, study club learning has always been a really great way to learn. Like-minded people, common thought process. So I've been really involved with study clubs. I have a local study club I started 34 years ago when I was going to Dawson trying to learn how to implement this. Mark Piper and I ran a study club for 12 years till Mark retired. Mark's been retired a while now. And then I started the Chicago Study Club with Kurt Ringhofer, Drew McDonald, who's an orthodontist in St. Petersburg, Florida, and Seth Atkins, who's a dentist in Texas. The four of us run the study club. It's a restorative TMD-based study club. It's fabulous. It's 2 days in the spring, 2 days in the fall. It's always in Chicago. It is invitation only, so if you'd like information on that, you can email me at jim@mckeedds.com. The reason we keep it invitation only, honestly, is to protect the learning environment. We have probably 30, 32 dentists, and it's just fabulous. We meet October 1, 2 in Chicago this year when we meet at a place called Gibson's, which is a steakhouse in the western suburbs. It's right between O'Hare and Midway. You're about a half hour from each. There's a hotel across the street. It's easy. You're in, you're out. Great people, great learning, hands-on lecture, a combination of all different things. I'm also out at Spear Education. I teach the Advanced Occlusion Workshop at Spear. But really what I've been focusing most of my time on is an online program for Stephen Phelan from Phelan Dental Seminars. Stephen's a dentist in Toronto who is way ahead of the online game. He's been putting out online courses for probably 10, 12 years now. So he asked me if I would do a TMD one for him. I said, sure. Not realizing how big the apple was I was taking a bite out of. So I've got 8 of the modules done. It's a 10-module program. Each module is broken up into 8 questions. It's a really cool format. Lots of new cases. I'm also then going to do a bonus module with Drew McDonald, the periodontist, Tom Purdy, my radiologist, Brian Shaw, who is the oral surgeon, and Seth Atkins, who does a lot of the digital work. So it'll be the most complete collection of probably the concepts that Mark Piper and Pete Dawson started. You know, those are the ones that Frank Spear and John Coyce have built upon. But really, it's going to be a combination of the restorative things that we hear at Spear and Coyce with the joint base in Dawson, or with the joint base things you hear out of Piper. I guess that's really the purpose of it, is to match those. You know, I will still say that ultimately we need to bring more joint-based information to all the teaching centers. Fortunately, Spear has really done a great job. Frank brought joint-based concepts out to Spear Education probably 7 years ago. I think I've been out there that long now. So I have to credit Frank for really creating an open mind. He brought Jeff Rouse out to talk about airway issues as well. So Frank is, I think as an educator, has really hit the mark on trying to bring out new topics. So, but those are the things that I'm doing in education today. We'll see. I just got asked to write another textbook chapter today, so that'll keep me busy. But it'll be, it's a fun time. It's a fun phase in the career.
Yeah, Jim, I am so eternally grateful for your relationship, your mentoring, sharing your knowledge on the podcast. It's awesome. So thank you for being here today again, my friend.
Well, the feeling is entirely mutual. Again, thank you for all you've done. I always say there's givers and takers in dentistry. Kirk Behrendt is a giver. He gives way more than he takes. So it's wonderful to be part of this. Thank you.
Well, I'm just so grateful. I love CE. And so I hope you guys that are listening are enjoying this as much as I am, or we are. So Jim, stick around while we say goodbye to everybody else. Thank you guys for listening to the Best Practices Show podcast. If you enjoyed today, which I hope you did, hit the share button, keep sharing with your friends. I don't know how the prep podcast is growing, but I'm so grateful. We're going to keep bringing it. I got Jim lined up for the end of the year, and I'm going to encourage you, if you're listening today, check out what Jim is doing. I don't care if you go to Spear, his study club, Phelan's things, DOT. We're going to put links to all of it in the show notes so you can follow there. And until we see you guys next time, or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.